Good
morning. I'll call the Kansas County Health and Human Services Committee meeting to order. We have, you were sent the, well, first of all, let me ask if everybody was able to open up the agenda with our new technology.
Yes.
Seeing smiles and nods, so everybody should be good. I was telling.
Did you want me to do an overview? Does anybody want me to show you? I have it pulled up before we would get started.
I think we're good. We should have the overview about getting it downloaded as well. For Noe, with me anyway. So no, it looks great. And so in that packet, in the iCompass packet, you should have the minutes from the last meeting.
I read them and I will move that we approve them.
Commissioner Nissen moves on the minutes. Do I hear a second?
I'll second.
Commissioner Gardner seconds. Any discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, same sign. Motion carries. There are no agreements, contracts to deal with today, so we'll go right into the general business discussion updates. Carol, unless, Jenny, did you have something you wanted to talk about before we get rolling?
I don't, just if anybody had any questions on how to navigate the iCompass, I'd be more than willing to help.
Okay, and I think, if anybody has any questions, just, stop us and ask if you're not finding something, because I'm sure Mary will be able to help us.
All right.
Morning.
Morning.
Good morning.
I'm here to give my annual report for finances, human services, and public health. If you'll look at your screen, the top portion doesn't change. That just gives a history of how human services is financed in the state of Minnesota. The middle section here gives you a snapshot of our expenditures and revenues for 2020. I'll start with expenditures. Personnel, of course, makes up the biggest piece of the pie because we are a service agency. The next biggest slice would be our purchase social services. That is services we purchase on behalf of our clients. The biggest piece of that would be our foster care placement costs. Also, home-based services, which is a service where Woodland Centers goes into the home, does skills training with families for reunification, and also other mental health services would be our next biggest chunk of that purchase social services. Revenues is next. Our expenditures, a lot of those actually, most of those, if not all of those, are mandated services. We don't have a lot of flexibility there. There are services we have to provide. Our revenues is where we really work very hard. We get creative and we do everything that we can. So our revenues, I'm going to talk actually at length about our revenues. Our tax levy only makes up 40%. The other 60% comes from other sources. Managed care revenues, part of that is that Blue Cross contract that we have decided to end, and I'll get into a little more detail about that later, but that is billing our managed care products, which are UCare and Blue Cross. Fees and other revenues, that is, we do, by statute, charge parents whose children are in placement. They have a parental fee, and we do aggressively collect that, again, within statute guidelines. And also, a part of that would be detox fees and also licensing of daycare centers and adult foster care centers. Recoveries, public assistance, purchase social services, that is if there's found to be clients who weren't eligible for funding, especially for MA and SNAP and those sorts of things, my staff collects on those, again, as aggressively as we can. Then the next two biggest slices of the pie are our federal and state funding. In DHS, we call those allocations. It's a pot of money that comes with very specific requirements for each one. And also in that is our billing to MA for our case management services and also our time study revenue. State and federal, 50-50 for that. And then the highlights, things I wanted to talk about specifically for 2020. The Executive Order 2012 allowed our staff to use telephone or video conferencing instead of face-to-face requirements for case management services. Of course, that happened early in the pandemic. This included our targeted case management and our waivers. This change did not have a negative impact on our revenue for client contacts in 2020. Staff actually were reported being home. There wasn't as many distractions. They were very efficient, were able to get their contacts with clients. Of course, clients were also at home in 2020, which helped. They didn't have to try to track them down. But again, the telephone and video conferencing worked very well staff working from home. The next section gives you some detail. We've never gotten this much into detail on the revenues. We talked about when we were deciding to end the Blue Cross contract, where those staff would go. So I want to point out that, again, our social service staff generate revenue. They work on case management services. So if you look in here, the core elements required for billing: eligible providers, that's our social workers; eligible recipients, that's our clients who are on MA; and a case plan specific to the client. Basically, that's like a prescription. That's the social worker saying, this is what this child needs, this is what this family needs. And then they have a plan, and the client or the parents have to sign this plan. And that allows us to bill. Every social service unit generates case management revenue except MinChoices, which we talked about, which is paid through the time study. So there's not a direct connection between this client and this payment. Case management there is, it's client A, we get this much money. Time study is a random moment, and we get just a lump sum. So there is revenue there. The target case management is what I've outlined here first. That is a per month amount. So we may have one contact with a client and get $186 in a month, or we may have a contact every day with a client, and we would only get the $186. Those rates usually change every year. The waiver case management is down below. That we bill every 15 minutes. If you look at that rate for 15 minutes, you might think that's pretty good, which it is. However, that rate hasn't changed since 2015. While our salaries and our benefits continue to increase every year, that rate has not changed. So again, we do everything we can to generate revenue. Our staff are very keyed into this. I mean, we're a service agency. They focus on the clients and what's best for the clients, but then they've always got my voice in the back of their head telling them to document what they're doing. Okay, the next page. We'll go to... The top of this page comes from a DHS report. It's a very large report, and it's always 2 years behind. What I want to show you here is, in 2019, the residents of Candiota County received just under $133 million in human service benefits.
Carol, I have a question. It
Yes.
shows, human service total revenues on your prior graph at 19 million, and where's the other 100 and some million coming from? Is it direct from the federal government to our clients, or is it, because...
Yes. So you're talking about still this graph. Yes. So these are payments, most of this is payments made directly to clients or to providers. The orange section, the biggest section is MA. So again, that's paying ACMC, Rice Hospital, the nursing homes. Yes. So that is usually to clients and providers. What I want you to see here across the bottom of the black line, that is our human service budget. Although it has increased slightly each year, it has not increased as much as the other areas. So we do our best to keep this line flat. But I want you to see again the picture of the total benefits to our residents. The other two areas on this page I'm going to talk about in depth a little bit later. So we'll just keep moving. Okay, yes. So human services revenue. This page is nice because it gives you a little bit of the history, right? You can look for trends. Our tax levy has been about 40%. I mean, it remains that, with the federal portion and the state portion coming in second. And I just want to talk again a little bit about the managed care revenues. Although we are ending our contract with Blue Cross Blue Shield for MSHO services, we will continue to have that slice of the pie. MSHO is about $750,000 of that. The other part is our billing managed care products for mental health targeted case management. So we will continue to have that. And again, our state and federal portion is allocations and also our billing services for case management, as well as the time study. So really not a whole lot of change. Again, the biggest change now will be that managed care slice getting a little bit smaller, but then the others should get bigger. And now we'll go to the expenditures. And again, personnel is the biggest piece. Purchase social services is the next biggest piece. Mandated services, whenever Jenny and I do the budget, we work with the supervisors and talk about, okay, what are the mandated services? What do we have to provide? Although we would like to provide other services, and we can see a benefit in those, especially the prevention services, which we don't get direct funding for. But again, we go back to what is mandated. What do we have to provide? Now we're going to talk about the levy and cash balance. Because Human Services is a special revenue fund, we have to maintain our own cash reserves. The Office of the State Auditor requires us to have between 35 and 50% of our operating budget in reserves. So as our budget grows, our reserves also have to grow. So the trick here is to, again, not raise the levy too high that we have that cash balance go too high, but also not have to dip into our cash balance so that it goes too low. I have partners in other counties who have had both of those problems. The auditor is dinging them for being too high and too low. So when you think about the volatility of our expenditures, again, especially the mandated services, we could have someone in Anoka County RTC who does not meet medical necessity any longer, and then we are required to pay 100% of that stay. That's $1,500 a day, $43,000 for a month. So again, that could eat into our cash reserve quite quickly. The next page is just, again, more detail, easier to read, I guess, with our total benefits coming into our county for Human Services. And then we're going to touch on public health next. Again, nice to see the 3-year trend. In the Department of Health area, they call them grants, not allocations. It's the same thing, a pot of money with very specific requirements to be able to spend that money. So that makes up the biggest piece of our pie. The fees next, 9% for 2020. That is our licensing of food, beverage, and lodging, and also tobacco. The LPHA grant, that is a state grant. That is basically our infrastructure grant, which has remained very stagnant for many years. However, in 2022, we have some good news. We will get about $25,000 increase in that infrastructure grant. A lot of that has to do with COVID.
Excuse me, Mr. Chairman. Could you explain LPHA? What does that actually?
Local public health agency grant.
Okay.
Yeah, again, an infrastructure grant just to have us exist.
Okay.
No specific requirements, basically a block grant. Here you go, you need to exist, we're helping you with infrastructure.
Okay.
Unlike the other grants, again, which have very specific guidelines on how to spend it.
I had a question, Carol. That $25,000 increase, is that a permanent increase or is that a 1 year?
We're hoping it's permanent. I'm looking at Jenny, we're hopeful.
Okay, good.
Yes. Insurance billing, this is billing the PMAPs, again, UCare and Blue Cross mainly, but then anyone who walks through our door with any private insurance, we bill. We are very creative and very aggressive, and we bill everything that we can. The contract piece, that is, we have a contract with Prairie Lakes to do nursing services there. We have a contract, we do preschool vision and hearing screening, and also our child and teen checkups grant with DHS is in that. And also the flu shots. We still do on-site flu shots with local businesses, so that's also in that section. And again, not a lot of change over the years, pretty consistent. Again, the thing we're most excited about, of course, is our LPHA being increased.
Any questions for Carol?
Yeah, I'm sorry, yeah.
Thank you,
George.
Mr. Chair. Any COVID dollars, revenues, reimbursement showing up on this yet?
Not really in 2020,
Okay.
not yet. Jenny, do you want to add?
Yeah, no, that is right. And some of that we won't see necessarily in our county allocations, it would be in our CHB. So remember in public health, we have a CHB budget, and that's where some of those will then be, outlaid and not in this.
I'm sure Commissioner Anderson wants to know what CHB is.
Yeah.
Community Health Board.
Okay.
Yes, yes. There is some, and again, it would be under the grants section, because again, MDH is
That's
always
what I was
grants.
wondering.
Yes, there was some early in the year, but that went very quickly.
Okay.
Commissioner
Yeah,
Anderson.
Mr. Chairman, then one question, you said you go to businesses and help give flu shots or whatever. If those businesses have health insurance for their employees, does that get billed then?
We bill the health insurances, yes, and then we also have in our contract that if the health insurance doesn't pay, then the business is responsible to pay that.
All right. Thank you.
Yes.
So, Commissioner Anderson, they will be offering, or Public Health will be offering flu shots to us,
Okay.
probably within the next month or so, and we get to pay too.
Okay. All right.
Bring your insurance card.
Okay.
Commissioner Gardner?
Thank you, Mr. Chair. And had Commissioner Anderson not wanted to know what that was, I would have. So, quick question, going back to the case management, just for the public, so they understand, and, well, so we understand as well. When we are talking about those types of things, those are services that are mandated by either the state or federal government, correct?
Yes,
Okay.
they are, yes.
So that means that we have no choice. We have to provide those programs no matter what.
Right.
And then I would assume that the ability to bill is also authorized by those entities, correct?
Yes.
We're not out there creatively looking for fees to stick people with. This is what we need
Yes.
to do in order to support those programs.
Right, yes,
Okay.
right.
And one other question that I had very briefly, when you're talking about the reserves, is there a recommended ratio of reserves to the total budget?
35 to 50% of the operating budget should be in reserves at all time.
Okay, so
And some have gone low and some have
this
gone
falls
high.
on the little higher end of that.
Yes, currently.
Currently.
And again, you know, a bad month could certainly affect that, but yes, we're very diligent, and I send that report every month to Larry and Jenny, so they know where our cash balance is at.
Yeah, outstanding. Thank you.
All right.
All right, now we're gonna look at the dollar bills.
Yep.
You probably can get there quicker than I can.
Nope, you're on the right one.
Okay. So these next ones, we've done this for a few years, this graph, if you will, to show you. Of course, I have printed copies, which is nice to be able to have them.
Click it one more time.
And for your commissioners, this is a good tool to have when you meet with your constituents, kind of show them where the dollar, that's a good visual.
So the blue heading, for every dollar spent on human services in Kansas County, again, this is the total dollars, which goes with that graph. Again, payments to clients directly and to providers, GRH homes, clinics, hospitals, nursing homes. So again, like I mentioned before, the biggest piece here, 61.5 cents of every dollar goes to medical assistance services in our county. Then it would be the adult services, trying to keep people in their homes and not having to go into a facility.
Can I make?
Yes, mhm.
So when you say every dollar spent, it's regardless of where that dollar came from, whether it came from the state government, the federal government, the.
Right, this is
tax levy.
all funding, and we have one
Thank you.
specific to local tax levy next. Okay. So again, medical assistance, especially since the Affordable Care Act has been looked at as being a national service, if you will. So that is the biggest piece of this dollar, which is just pretty much the exact opposite of our levy money. The biggest, the most money for every dollar spent of our local levy goes to children's services. Again, the federal government sees this as a local problem, and so the burden falls on us, how to pay for that, hopefully how to improve that, manage that. Then the next portion, highest portion goes to mental health, and then to the support programs, which is the SNAP and MFIP and that sort of thing. But again, it's interesting, and like Larry mentioned, to show your the voters, constituents, where the money goes. And then we're going to go to the public health one. I guess I should also point out, this data with these dollars is from 2019, where I'm actually, of course, doing the 2020 report, but that comes from this very large, detailed report, if anyone ever wants to see this. DHS puts this together. It's all counties' data. So this, again, it's always 2 years behind, so. So now if we look at public health,
If you study it, I know.
and I actually have 2019 and I have 2020. So if you look at the public health one.
Excuse me just a minute, Carol.
Yes.
Thank you.
Just want to just
Yeah.
finish and going back to the human services part. The dollars, we're talking about dollars, and you made it clear that the dollars were the total dollars when you look at it. So many 46 cents went for that. But going back to the comment about, where did that $133 million, and when you look at that, we're a regional center for human services and social services. And even though it affects our tax levy, revenue coming in from outside into our community is huge. This is a big plus to our community to get $133 million coming in for these services. And the majority of these services are contracted out, right? Directly go to the medical facilities, the nursing homes, the group homes,
Yep.
and all that.
Yes, and all the jobs that creates in our county.
That's the point. Yes, it does. And I hate to think of it in terms of economic point of view as being a plus, but it really is. Okay.
Anything else about the human service dollars?
Thank you.
So the public health, again, we're talking about 2019, but we did put together the 2020 bill if anyone would like to see it. And the main reason for that is we wanted to see the difference in responding to emergencies. I'm sort of jumping ahead. So the biggest portion of the public health dollars are spent on promoting healthy communities. Home visiting to expectant mothers and families, WIC program, follow-along program, teen pregnancy program. And then, of course, assuring the adequate local public health infrastructure would be the next biggest. But then if you look at 2019, if you go down, 2.8 cents were spent in 2019 on responding to emergencies. In 2020, that 2.8 went to 8 cents.
Wow.
Yes. So if anyone would like to see that, we do have the 2020 available. I don't think it's loaded here, but we do have that available if you'd like to see that. And then the last thing I want to talk about is, so we've pulled out, again, here is the full report. We've pulled out data that we think is most relevant, that you'd be most interested in, into this document. So back to Commissioner Berg saying that we're a regional center and all the money that does come into our county because of that. I want to point out one line here that I do just about every year. I point this out. How does Kansas County compare? Kansas County is traditionally ranked in the middle of Minnesota counties in per capita human services expenditures. If you are number one, that would mean that you spend the least dollars per person for human services. I want to say it was Carver. I have it here in front of me. And then if you're the last one, then you spend the most per capita. And I believe that was Monoman. But again, we always are in the middle. We don't spend the most per capita. We don't spend the least. So if there's a idea out there that, again, we spend the most of any county in the state, that is certainly incorrect. So again, if anyone wants to see the full report, but we've pulled out, I think, what's most important, most relevant.
Commissioner Berg?
And Mr. Kleindall, too, probably can answer this question. All this information that we have is currently then will be available to the public, right? So if they're watching or they want to hear more, refer back to this. They have the same information. This is very transparent, very good.
So all of our minutes and stuff goes in, when you go to the commissioner's boxes, or go to Health and Human Service website, you can click on there and this will stay there. So even years back, you can go on the websites and you can compare documents. Even back when you were the director, probably there's some things back there. I don't know if it's that long ago, but
But it's
They
a lot
probably didn't
easier,
have
it's gonna be a lot
computers.
easier to access and group it together this way. They just, one click and they got it.
Trillion.
Very well done.
Great.
All right.
Thank you.
Any other questions for Carol before she sits down? Well, thank you very much for that. Appreciate it, Carol. Okay, now we have an annual report from Corinne.
Good morning.
morning, Corinne.
Morning.
You survived that car troll weekend?
I was gone for the weekend, so I missed all of that,
We
but I
saw a
heard it
lot of
was
them going
quite,
through the intersection, so it was kind of cool
yeah, I heard there were quite a few of them, which is very cool.
and a nice day.
It's good for the neighborhood. I am here today to, also, like Carol, to be able to share some annual report information from 2020. And I'm going to start with our adult protection. Just to kind of do an overview for those who might not know all the details of adult protection, also considered vulnerable adult program in the state and in Candioi County. In order, adult protection is obviously very similar to child protection. It's about protection. It's about assuring and bringing safety for the health and of our vulnerable adults. To be a vulnerable adult, you obviously have to be 18 years of age. You have to be able to have a need, whether that need is being taken care of by a licensed provider, whether that need, you have a need that you're not getting any services for, or you have a need in which prevents you from being able to protect yourself. Those are components that have to be in place for us to be able to be involved from an adult protection standpoint. When we're looking at adult protection, we're really looking at being able to establish maltreatment. Did maltreatment occur? And when we're looking at those, we're looking at allegations of abuse. That could be physical abuse, sexual abuse, or we're looking at neglect. And that neglect could be a caregiver neglect. Maybe it's a facility that's neglecting the care. Maybe it's a family member that's neglecting the care of someone that they've acknowledged that they have caregiving responsibilities for, or it can be self-neglect, in which the vulnerable adult themselves are making poor choices and poor decisions that puts them at risk. And then we also have what's called our financial exploitation. And under financial exploitation, we're looking at people who have a fiduciary responsibility, meaning there's been a legal component, maybe that's a power of attorney, that's a guardianship, or non-fiduciary, which is someone who, typically will be a family member who has taken that responsibility, have acknowledged that responsibility, but they're considered what we call a non-fiduciary person. So those are the things that we look at in our adult protection. Were those different areas, those are the allegations, if you will. If you look on page 18 of your annual report, you'll see the different type of allegations that are laid out that we are looking at and addressing. So in the state of Minnesota, there's 3 different what they call lead investigative agencies. There's the Department of Health, the Department of Human Services, and then at the county level. The Department of Health investigates reports that are coming from facilities that are licensed by the Department of Health. The Department of Human Services are taking care of investigations on reports of a facility that they've licensed. They're licensed by the Department of Health. Everything else then becomes the county responsibility. We sometimes call them community reports, where your perpetrator is someone who is not in a staffing or licensed facility situation. They are a community person who has whatever community role with the vulnerable adult, whether that's the neighbor, the relative, any of those are considered community. And those are our responsibility to investigate. Years ago, 4 or 5 years ago, maybe 6 years ago, And it used to be that every county had an intake for adult protection, that if you had an adult protection report you wanted to make, you would make that call into the individual counties throughout the state. What they did is they changed that then to what they call the Minnesota MARC. It's the Minnesota Adult Abuse Reporting Center. So if anyone wants to make a vulnerable adult report, they are making that report to this call-in center. And as a mandated reporter, you're also able to do a web report. So that changed, like I say, 4 or 5, 6 years ago. So what happens is that those reports then go into this center, and then that center determines if that goes to the Department of Health, does it go to the Department of Human Services, or does it come to the county level? And then they also make a determination if there is an allegation of a crime, then they are also sending that out to the law enforcement center that would cover the jurisdiction for whatever that allegation or that crime is. So when we get those community reports, it's our responsibility to investigate that report. And we really have a twofold purpose in adult protection. We are looking to investigate that report, and we're looking to establish, has maltreatment occurred? We have to make a determination if maltreatment has occurred or not. And then our other piece of it is protection. What is needed for there to be protection for this vulnerable adult? If we're able to determine that maltreatment has occurred, what kind of things do we need to do and work with that person to be able to establish safety and protection so that maltreatment doesn't continue, it doesn't reoccur? So we have those two roles or responsibilities that we have in doing our investigations and our reporting. You'll see that the numbers did decrease some in 2020. And I think that 2020 is, I'm afraid, a year that we don't want to necessarily compare numbers to. On COVID, even though our numbers have decreased, COVID really has created a real struggle in 2020, and as we continue to be able to be challenged with how to best respond to these reports. And we want to make sure we're protecting our vulnerable adults who are obviously, some of them, very high needs and in a more dangerous situation because of COVID. We also want to protect our staff because of that. And it's become, 2020 was very challenging, and that is continuing to be challenging for adult protection workers. One of the other things that's really become challenging and why, even though our numbers are lower, our work has increased because we're having more difficulty being able to find those services, being able to pass that responsibility maybe onto a different level. So we might get involved in a self-neglect case, for example, and that person is really feeling like, okay, maybe it is time that I need to be getting some services going. Maybe it is time that I start getting on those wait lists. Maybe it is time to reconnect with my doctor. So then that's part of what our worker will do, is really work with them and be able to try to establish that plan. How do we get you going? How do we get you connected with those services? Well, we have found with COVID, obviously that's being limited. And so we're hanging on to those cases longer. We're needing to stay involved longer because we're not able to do that pass off as quickly and as easy as we have in the past. So I think that's probably our biggest challenge that we've seen with COVID, and also that even though our numbers have decreased some, which I believe is also a COVID thing, but the work we're doing is much more intense and much more, like I say, longer involved in those situations.
Commissioner Gardner.
Thank you, Mr. Chair. Corinne, I'm looking at the chart that gives us the total community reports. And looking in 2014, 2015, it looks like those are maybe about 2/3 of the numbers of what we've been seeing over the last 4 or 5 years. What's driving that increase? Are there factors at play we should know about?
The biggest factor that's driving that is when we went from the change, when the state went from the change from local on intake, local phone calls, to going to the reporting center. So one of the things that changed in that is when we would get a local phone call, our intake worker would be able to process and talk through and in reality be able to process through some of those reports that we would be able to say that they're not meeting that need. They're not coming up to that level of being a vulnerable adult report. At the center, it's you make a phone call, they're typing in the information that they get, they're not asking questions. And so we saw a huge increase in the reports that came, and I would say that's our biggest increase.
Okay.
Plus, I would say that there's more vulnerable adults in the community than there has ever been, which isn't a bad thing, except that then that increases our need to make sure that protection is there or on more reporting that's happening because there are more vulnerable adults in the community.
Thank you.
Could I?
Commissioner Anderson?
Yeah, so I have a question. A lot of these elderly people, they don't want to bother people, and so then they don't tell people they got something going on. So how would somebody get a hold of you guys? They just look up Health and Human Services, or a lot of the elderly don't have access to internet and stuff like that. So how would they get a hold of you?
They can make a phone call to us, and to be able to, you mean as being able to get services and be able to make that, yep, just a phone call to us, and they would talk to our social service intake, who would then be able to process through what makes the most sense. Is it that it's something that they could do in a screening with Min Choices to be able to address those services needs? Is it something that they have a mental health issue that we can make that connection with their mental health unit? It depends upon how they identify that need. One of the things that's important to, when you're talking about vulnerable adults, just because you meet the criteria that allows us to be involved in doing an assessment, doesn't necessarily mean when we get out there that they really are meeting that need, that they meet that definition is what I should say. A 5-year-old can't choose to stay home alone. An 85-year-old can choose to stay home alone. So what we're doing in those situations is we're really assessing what that competency for that person is. Are they able to protect themselves from maltreatment? Are they able to cognitively make their choices? Lots of adults make bad choices. That doesn't mean that we get to go in and tell them what choice they need to make. And so we really have to be assessing what that cognitive ability is. We rely then on who are they connecting with? Are there family members who have seen them on a regular basis? Are they seeing a decline in their functioning? Are they seeing a doctor? What is the doctor seeing? Do they have service providers? What are those service providers seeing? And so the just because you're 18 or older, just because you have a service, or just because there's not this automatic, well, now we get to tell you what to do. They still get to have choices. And that becomes sometimes the most frustrating for some of our people who report to us. Well, they're making bad choices. You need to do something about that. And it's that ability to sort through with family members or to sort through with neighbors that they're still an adult. They still have that ability to make choices. And that can be a real fine line sometimes. When are they incompetent? When aren't they incompetent? And when are they truly a vulnerable adult? When aren't they? My workers would tell you that one of the hardest decisions that they make is screening decisions. Are they a vulnerable adult or not? Because there's such a fine line, and this person may be because of circumstances. Those same circumstances in another situation may create not being enough for us to do something about. Senior Linkage, sorry, I'm kind of went off on a tangent there. Senior Linkage line is another really good resource for people because they do a really good job of just what are those scenarios and how can they connect them most appropriate when there isn't a maltreatment issue going on, where it's just a senior, excuse me, needing that service. And so, like I say, some of our challenges in 2020 was really the ability to be connecting people to services, to being able to really look at the protection piece of our responsibility. Self-neglect, as you'll see from the allegation summary, self-neglect is our highest. They also are our most challenging. There is there's task force on pieces that are really looking at the maltreatment piece as it relates to self-neglect. It can be very difficult to say someone is responsible for maltreatment for self-neglecting themselves when in reality they don't have the capability to do that. And so it's a weird process that our process is the same whether it's somebody who has sexually abused a vulnerable adult or a vulnerable adult who is self-neglecting themselves. And so there's been lots of conversation. There's task force that are in place now to really look at how our process is and are there other ways or other avenues to be able to really deal with the self-neglect cases. One of the other things under adult protection that we're seeing a real increase in, and you'll see on the data. Trying to find the right page for you. I don't think I have that page. But our emergency protective services, you'll see that there's a column for 2020 because we really have seen an increase in that. So we are going to start really looking at that for data purpose. What emergency protective services are is that someone who did that intake is saying that they believe within 72 hours this person is going to need to be seeking medical care. They're going to be at risk of health and safety at a higher level. And if they're checking that, if that box gets checked, then we are required to go and do that emergency protective services within a 24-hour standard of time. As well as under emergency protective services. So it may be a situation that we don't have investigative responsibility, but we have that emergency protective. So it may be a situation where the Department of Health or the Department of Human Services has that responsibility. So the investigative responsibility. So let's say it's a staff person and is the alleged perpetrator. If it meets that standard, then we're required to at least go out and make that initial emergency review of it. So we're not investigating if that happened or not. We're just investigating and making contact to make sure there's immediate protection. So using that example of, let's say it's a staff person, that's your alleged perpetrator at adult foster care. Our role is to make sure we're making contact with the provider, contact with the vulnerable adult to make sure there's immediate safety. Given that example, typically what will happen is your provider is suspending that person pending investigation. They're not providing direct care, those sort of things. But our role in those situations, even though we're not doing the investigation, is just to be assuring that there's the emergency protective piece is in place. So we are seeing an increase in those reports.
Commissioner Bird.
Thank you, Mr. Chair. The emergency protective services, and that's something you just started recording separately, and that's not part of the total community reports then at all.
Yes, well, it may become part of it because we may have an emergency protective service, may be kind of that box that's checked in that requirement to be within 24 hours. Then that may move into an investigation if it's a criminal or a community perpetrator. It would not move into that if it's a facility, for example. Okay. That example I just gave, that would not move into our community numbers.
Okay. But you were following those up before, though, right? Before this year. you're still dealing with those cases.
Yes,
It's
yes.
kind
What
of-
we've, the reason that I added that is that we've just seen such an increase that I just really think we need to start paying attention to what that means and what that really looks like, because that does create that 24-hour response.
Okay, so in a sense, you're saying the numbers were down. We don't really know if they're down.
Yeah,
they could be.
that's true. That's a good way of looking at that.
So
Yep.
it's still a major challenge.
It's still a
Getting-
major challenge.
Getting to be more major all the time.
Yeah,
Good
yeah.
report, thank you.
All right.
Other questions on that? It looks like we're probably done for today. All right, thank you much.
Thank you very much,
Thank you.
Corinne, for
Thanks,
that,
Corinne.
all that information.
Good job.
If there's nothing else come before the Health and Human Services Committee, we will stand adjourned.